The Committee on Emerging Issues will come to order. Please call the roll.
Chairman Patterson.
Here.
Vice Chairman Davidson. Representatives Ani. Cupps. Fitzwater. Vogel. Gregory. Hafner. Hicks. McCrary. Ritchie. Sauls.
Here.
Smith. Taylor. You have.
Regrettably, we do not have a quorum, but we will take public testimony anyway. We will hear House Bill 1741 from Representative Dogan. Representative, please proceed. Thank you for being here.
Thank you so much, Mr. Chairman. Thank you, committee members. Representative Shamed Dogan from the 98th District. We are here to hear House Bill 1741, which is my bill on oral contraceptives. This is something that most of us in the body have seen before, but for the benefit of you freshmen who may not have, this bill is about allowing pharmacists to dispense oral contraceptives to women who are 18 years or older when they have a prescription that's pre-existing. And this is something that expands access to contraception. A pretty sizable percentage of women use contraception, both oral and other forms. The latest estimate I have is that approximately 14% of women ages 15 to 49 currently use birth control pills. Many of them use it for the purpose of contraception. Many of them use it for other purposes. Plenty of other health reasons that women choose to use oral contraceptives. And in terms of contraception, it does help to reduce abortion rates, which is something that I am very concerned about, and many of my colleagues share the concern that one of the most effective ways for us to reduce abortions is to reduce the demand for them. And when women have access to reliable, safe, effective forms of contraception like birth control pills, that does reduce the demand and the need for abortions. So I think this is something that is a win-win. It's something that has been supported by folks on both sides of the aisle. I think the last time we passed this bill out of the House was 2019 when Representative Solon carried this piece of legislation. And it is being currently done in 18 states. And so we would not be some sort of, vanguard on this type of legislation. And the one piece of this that has been brought to my attention that some folks do have an issue with is on page 4, where it says that the order for these contraceptives shall have no expiration date. And so I'm expecting that there might be some discussion among the committee members to change that, to make that some sort of a finite supply, whether it's a year, whether it's a couple years. I'm open to that change. Mr. Chairman, if you and your committee and your infinite wisdom do decide to amend that portion of the bill. So happy to take your questions.
All right, thank you. Thank you for being here today. Yeah, that was the one concern I had too. It says on page 5, on line 26, at least once every year, refer the patient to the patient's primary care practitioner. But if they didn't, they could still keep getting, under the current bill, they could keep getting the oral contraceptives.
They do have to go back to their primary care practitioner, but the order for the contraceptive is technically without expiration.
Okay, so that, I think we could work on that.
Might need to sync those two pieces up a little bit. So.
Yes, I would agree with you. Thank you. Questions for Mr. Dogan? Representative McCreary.
Thank you, Mr. Chair. Dr. Patterson, I actually have a question for you about other prescriptions. They generally don't expire, do they? For other categories of drugs?
Oh, I think prescriptions do expire.
Okay, so
Yeah,
the prescriber would write the date.
Right.
And then it would
are you talking about after you dispense the drug, there's only so many refills that you can give?
Well, that, or say a physician or a prescriber, it doesn't have to be a physician, puts the date, I'm using the old-fashioned paper pad.
Right.
They put the date, they write what the prescription is. Is that good for only so many days after the date that the prescriber writes?
That's an interesting question.
I don't know, because
I think that's more up to the pharmacist. Because-
I think consistency
Yeah,
would be
that's
what
some
I would
wording
be
that we
going
could put
for.
in there.
Okay, very
Right.
good, thank you.
Any other questions? Representative Ani.
To inquire. Actually, just to make a brief statement, I just want to thank you for bringing this piece of legislation forward. I do think it's incredibly important for folks to have even more access to contraceptives. And as you pointed out, women can potentially, and folks who use contraceptives could be using it for things other than contraception and birth control. I think that that's really important to acknowledge. And I also think it's really important to acknowledge that the more folks who are taking oral contraception or other forms of contraception are folks who are less likely to need an abortion. So thank you so much. I really appreciate it.
Thank you. Any other questions? Thank you, Representative Fogel.
Thank you. Just to walk me through something, because I genuinely don't understand. So obviously, and this actually may be for you, Dr. Patterson, obviously there's oral contraceptives and then there's emergency contraception, correct? Two separate things categorically. And right now, you don't have to have a prescription of any kind. You can get as many as you want for emergency contraception. But this only applies to oral contraceptives, which would be anything preventatively and not including emergency contraception.
That's right.
Okay.
And that's one of those weird inconsistencies that this is designed to address, the fact that you can get emergency contraception completely over the counter.
Right.
That makes no sense, and you have to go to a doctor and all the expenses and all the time that incurs on someone, especially when you have people that have what they call contraceptive deserts, whether you're in a rural area or you're just in an area with few doctors. That's a hindrance towards people getting contraception.
Right. Okay. Thank you so much.
All right, thank you. We will start with witnesses in favor and then alternate with opposing. Please remember to fill out a witness form if you testify, and remember to speak really directly into the mic. This mic acts kind of funny. We'll start with witness in favor of the bill.
Good evening, Mr. Chairman, members of the committee. My name is Jeremy LaFavor here today on behalf of Empower Missouri. Empower Missouri was founded at the start of the 1900s to convene coalitions in the state around a number of ways to improve the lives of Missourians, and one of those ways is through a number of healthcare coalitions. We stand in firm support of this legislation. It provides families and women the ability that empowers them to take control of their family choices and makes life better for a lot of folks. So I want to go on record in support, and they submitted some testimony online that's in the inboxes as well.
All right, thank you, Mr. LaFavor. Questions? We'll take a witness in opposition of the bill. Are there any witnesses in opposition? We'll move back to witnesses in favor.
Thank you, Mr. Chairman, members of the committee. Mandy Hegseth on behalf of Missouri Family Health Council. For 40 years, Missouri Family Health Council has been the Title X Federal Family Planning Program grantee for the state of Missouri. We also administered The Right Time, which is a contraceptive equity initiative funded by Missouri Foundation for Health. Last year, our network served 40,000 patients. As the state family planning experts, we thank Representative Dogan for his leadership on this issue, and we do support HB 1741 as an encouraging first step to reduce barriers facing people trying to access contraception. We have supported this legislation for several years in the past. We know that this creates additional pathways to care. Pharmacists see patients often, sometimes as much as 12 times per year, which is especially important for rural Missourians and those with limited resources. My figure is actually that 22 states allow for this, but somewhere between 18 and 22 do allow pharmacist dispensing on some level. And we know that there is bipartisan support that runs deep and wide, both here in Missouri and nationally, on legislation like this. According to a recent public opinion poll that we conducted under the Right Time Initiative, 76% of respondents said that they would like to see the legislature do more to increase access to birth control. 75% believe that more should be done to improve access within their communities. Among the greatest barriers that people experience accessing contraception here in Missouri, lack of time and lack of a nearby clinic were among the top two choices selected, both of which would be impacted in some way by this legislation. In order to effectively meet Missourians' needs, contraceptive needs, that is, we would like to see the bill be amended to include additional contraceptive methods of the vaginal ring, patch, and shot, and the age restriction be removed. In 2021, of the patients seen by our network and who used contraception, 38% did use oral contraception, which admittedly is one of the most popular and beloved forms, but almost comparable amount, 34%, used the other three moderately effective methods that I had mentioned, the vaginal ring, patch, and shot. In addition, 22% of those that we served in 2021 were 19 years of age or younger. So in order to fully meet the contraceptive needs that we've experienced in our 85-plus health centers across the state of Missouri, ranging from federally qualified health centers, county health departments, community action agencies, hospital-based clinics, and standalone family planning providers, we would like to see some additional elements address some of their needs. Nonetheless, we believe that this is an important first step to reduce barriers that people experience accessing contraceptive care here in Missouri, and for that, we support it. We hope you do as well. Thank you so much.
Thank you. Questions, Representative Sauls.
Yes, thank you. To inquire briefly.
Please proceed.
Thank you. Just real quick, you mentioned some concerns. Did you bring those concerns up to the bill sponsor as far as what you'd like to see different?
We talked about it briefly, yes.
Okay. All right. Thank you.
Representative McCreary.
Thank you, Mr. Chair. Thanks for being here. So one of the things I wanted to hear your thoughts on is for oral contraceptives to be most effective, they need to be taken at the same time every day, and that can be really challenging for some folks that have erratic schedules, for example, like, somebody that works a morning shift at a diner, but then like the next day they don't. So can you talk through why it might be best for patients to also have the option of having the ring, the patch, or the shot, as well as it relates to efficacy? If someone's going to go to the effort of trying to be responsible and prevent an unplanned pregnancy, why are some of these other products good options as well?
Thank you for the question. As the Director of Policy and Advocacy, I will stay in my lane a little bit. I would be happy to provide additional information to all of committee members about the specifics of use and efficacy of all methods of contraception, but I can tell you briefly that yes, most oral contraceptive pills you do have to take every day, whereas the vaginal ring, patch, and shot are taken far less often. I'm a little out of practice on the vaginal ring, but I believe that you leave it in for 3 weeks and remove it for a 4th week or continuous cycle if you wish not to have a period. With the patch, I believe it's once a week. Neither of these are every day is the point. And Depo-Provera or whatever subcutaneous shot, that would be on a much longer level, right. Months. But I can provide specific information from clinical folks within our network.
Well, and I hope I didn't put you on the spot. I wasn't wanting to have a medical debate as much as I want my colleagues to understand that for some folks, it can be very challenging because of life challenges, family challenges, to remember to take something at pretty much exactly the same time every day. And I think these other options are something that can help folks out.
And if I may, one thing that I think is really important that is within your question, Representative McCreary, is paramount to efficacy and quality family planning care and services is patient-centered care and patient choice. And so when we limit the amount or the types of birth control that people can choose, we're limiting sometimes, people have different preferences, they have different lifestyles, some have different allergies or other indications that prevent them from taking certain kinds of methods. So it's really central, and you will hear Missouri Family Health Council say at every turn that patient-centered healthcare is key, and quality family planning rests on people being able to choose the method that is best for them.
Right. So in that example, it's not just the convenience factor and efficacy, but it could also be related to the side effect profile as well.
Absolutely.
So very good. Thank you.
All right, thank you. Thank you for being here today. Thanks for your testimony. Next witness in favor of the bill. Are there any other witnesses in favor? Are there any witnesses for informational purposes only?
Good afternoon, everyone. Chairman Patterson, members of the committee. I'm Jill Barnes. I am the Human Services, Public Safety, and Corrections Policy Fellow with Most Policy Initiative. For the record, Most Policy Initiative is a nonprofit, nonpartisan group based in Jefferson City, and all we try to do is just provide research information and place that into the hands of the legislature. Today, I'm here to just testify for informational purposes only regarding House Bill 1741. I'm also summarizing sorry, I keep turning my head. I'm summarizing a brief that has also been submitted for testimony as well, and it's also available for free on our website. And really quick, before I dive into my testimony, I just wanted to say that in this brief, we do go through each birth control method, and we talk about the mechanism of action. So it's free and it's available on our website, so I highly recommend that you go and check it out. So I won't try to be redundant here or anything like that. So as everyone has already kind of mentioned before me, prescription contraceptives, they are the most widely used form of birth control. And there's a variety of social determinants of health, such as poverty, lack of insurance, and accessible health care that can create barriers for prescription contraceptive access. And so when individuals have difficulty obtaining these prescription refills, they may experience gaps in their use or stop using contraceptives altogether. And this really can disrupt that mechanism of action that we kind of talked about. And for these drugs and devices really to be effective, they need to be used consistently. And when they're not, that can lead to unintended pregnancies. And so due to the non-addictiveness nature of contraceptives, various medical organizations, such as the American Council of Obstetricians and Gynecologists, they want to improve access to contraceptives by being able to obtain them without a doctor's prescription. But concerns about over-the-counter contraceptive use without a prescription includes a potential decrease in preventive screenings. It can change the patient-provider relationship and access for those with insurance that requires prescriptions for cost coverage. As mentioned, there are numerous states with statutes and regulations that allow pharmacists to prescribe contraceptives. These laws vary between the states, such as what prescriptions can be provided by a pharmacist, in addition to age restrictions. It's important to clarify that while most states are increasing accessibility to various birth control methods, research surrounding best practices for who distributes these prescriptions, such as physician-prescribed or pharmacy-prescribed, and the over-the-counter status are still ongoing. And so as more information becomes available, we're happy to update the committee with that information. And with that, I will try to address any questions you might have.
Questions for the witness? All right, thank you. Thank you for being here today. Any other witnesses for informational purposes only? That will conclude today's hearing on House Bill 1741. Thank you, Representative. We will now take public testimony on House Joint Resolution 128. Representative O'Donnell, thank you, and please proceed when you're ready.
Thank you, Mr. Chairman, members of the committee. For the record, I am Michael O'Donnell. I represent District 95, the southernmost part of St. Louis County. Today I'm here to present to you House Joint Resolution 128, which has to do with investments for the Treasurer's Office. First, this joint resolution would seek a vote of the people to do three things. First, to allow the Treasurer's Office to invest in highly rated municipal bonds. And I've passed out a chart explaining bond ratings because the way it's written in the HJR is that we would allow the Treasurer's Office to invest in the top 5 long-term ratings and the top short-term rating based on a national nationally recognized rating agency. This HGR would also allow the Treasurer's Office to invest in 7-year, which it currently is allowed to invest in 5-year treasuries and federal agency bonds. The yield pickup there tends to ebb and flow. Right now we're seeing a pretty flat yield curve, so there's about 10 basis points between the 5 and the 7-year Treasurer. When we've looked at this before, it's been a lot wider. Last year, this time, the 5-year Treasury was around 0.4%, and the 7-year Treasury was around 0.75. So at that point in time, there was actually a pretty substantial yield pickup. Most other states, this works nicely, would not work nicely for Missouri if we allowed them to do it, because other states don't allow this, and so we would be moving into a space that other states don't operate, which means interest rates work on a supply and demand basis. If there's more people pursuing those securities, the interest rates come down. If there's fewer entities pursuing those fixed income securities, the rates go up. The last change to the state constitution would seek to allow a vote of the legislature to make any other investment changes. Markets move fast, and the ballot process does not. And it doesn't allow for changes to the investment policies of the state treasurer's office in emergency cases. And so a good example of this is, and we're actually seeing this right now with the changes in the treasury market. Some treasuries, in the very short end, actually have negative yields right now. The 1-week treasury has dipped into negative interest rate range, and the treasurer's office isn't allowed to do that. And so when we have low interest rate environments like we've experienced over the last few years, we might be able to put something in place that allows them to deal with that. And if we have to go to a vote of the people, it doesn't allow us to kind of make changes on the fly. Or in particular, example that was discussed with a group of us today was if we wanted to do something short term. So we were dealing with a current market situation, we could put something in place that allowed the treasurer's office to do something investment-wise for a year. I don't know that we've ever seen sunsets put into the state constitution, so it would be kind of odd to do that. But that's the reason for wanting that change. To one observation is in the fiscal note. It says that in the first year there could be a $7 million cost to the state. That would only be realized if the governor called a special election for this specific measure, which there's no good reason for the governor to do that. And then beyond that, all of the fiscal impacts are positive. And I think the last fiscal note I saw on it, based on where interest rates were earlier in the week, put the potential revenue to the state at around $14 million. So the increase in their investment portfolio would create some of these opportunities. The municipal bonds is probably one of the best examples right now. The spreads have gotten pretty wide there. I bought three-year municipal bonds that would qualify under this HJR around a 2.3% late last week, and the 5-year Treasury I think was around a 155, 160 earlier today. So there's a substantial yield pickup for not a huge increase in the risk profile. So that being said, I don't want to bore you with bond speak, but happy to take any questions.
Thank you. Thank you for being here today, Representative. Questions? Representative McCreary.
Thank you. You're not boring me at all. This is very interesting. So, and you're a financial advisor in your outside life?
I'm a bond trader.
Bond trader,
Yeah,
okay.
in my
All right.
other life.
So to be honest, I was surprised that the treasurer doesn't have flexibility to do what's best with the state's money. So can you share your thoughts on why so few states have the availability to do what you're proposing?
I haven't looked into it, but I know I've discussed with some in the treasurer's office some of the things that they're not able to do versus what other states, and I'm actually really quite surprised by it. But I think it comes down to that last part, and in that it has to be approved constitutionally. I mean, you and I deal with utility bills directly, and they make our heads explode. Think about putting something like that before the voters. And that stuff's really complicated. So every time the treasurer's office would want to introduce a new investment product, they would have to take that to the people and be able to explain it. I feel like when we drafted this, we tried to simplify it, one, just primarily because we don't want to overwhelm voters. We want to kind of keep it pretty simple, and we may have overreached a little bit. It may be a little complicated, but I feel like that's probably a big part of the reason is every time you've got to go to the voters, you've got to be able to explain it, and it can be difficult. One example, and I didn't realize this when I was having a discussion with the treasurer's office, was they're not allowed to invest in money market mutual funds. So the thing that you might put your money in just to earn a little bit of interest while you're waiting to maybe make an investment or buy a house or something like that doesn't give you a huge rate of return, but they're not allowed to invest in those.
Better than nothing. It's better than
Right.
zero return.
And they're typically very, very safe because they're invested in short-term securities. But currently, the state's not able to do that. And I would hearken back to the fact that every time we want to get a change like that, it's got to go to the voters. So.
Okay. So, one of the things that gives me a little bit of heartburn, though, is in order for someone to be our treasurer, they don't have to have a background in things. So can you walk me through why you would feel comfortable giving the treasurer, and the treasurer's the elected person. I think there are a bunch of really smart staff people that work in the treasurer's office, and those are folks that are not political appointees. They're actually people with expertise.
Correct.
So can you walk me through why
I think we have some of them here today, but you're exactly right. I don't think that an elected official would actually be
Right.
at the switch, making the call to buy a particular bond or something like that. That we've hired people. We have a chief investment officer who's responsible for those people that are making those day-to-day decisions.
Okay.
And they're think about those decisions. It's more than just what do we do with this money. It's what's the plan with this money? Do we need it tomorrow? Do we need it next week? Do we need it 5 years from now? Do we need it 7 years from now? They're making all of those decisions, and I would not trust any of us political types to be pulling the trigger on those.
Yeah, and I certainly don't want to seem that I'm a contrarian, but that's an elected position. They're 4-year terms. I would hate to see an elected official, who's already planning to run for another office, do something with our constituents' money, with the taxpayer money, that somehow ties the hands of other treasurers down the road too. So I think if there are other folks that can address, I would want to hear a little bit more about the inner workings of the treasurer's office to make sure I understand that they have the ability to hire experts. Like we use PIMCO, for example. There are people out there that are experts on municipal bonds, and I would rather see the state use somebody like that.
Right, and I agree with you completely. Okay. That's my understanding of how the treasurer's office is structured. So.
Very good, thank you.
Mm-hmm.
Thank you. Further questions? Representative Smith.
Thank you for bringing this forward. I think it's good to be financially prudent. Just a question I had about the language. I didn't know what your thoughts were about this. On page 2, I think 25 through 29, lines 25 through 29, it says, the treasurer may also invest in other reasonable and prudent financial investments and securities otherwise provided by law. Do you have a concern that that's maybe very broad?
Well, and that's the last component of what I'm talking about, is that we're actually changing the Constitution so that we don't go back to the voters anymore, that this is done by the legislature. And that's what that last sentence is about the legislature approving investments from this point forward. Investment types going forward. The legislature is not approving them buying a 5-year AA rated muni today and a 2-year agency tomorrow. It's the treasurer's office coming to the legislature and saying, hey, we'd like to be able to invest in money market securities. Would you authorize that? Instead of going back to the people, that part right there is specifically allowing the House, the General Assembly, and the governor to approve any of those going forward. So that's what that's doing.
Further questions? Thank you, Representative. We'll take testimony. We'll start with witness in favor of the bill. Thank you.
Good evening, Mr. Chairman, members of the committee. I am Michael Price. I'm the Deputy State Treasurer. Here on behalf of the State Treasurer's Office, we'd like to go on record in support of HJR 128. It's going to help us make more money for the taxpayers and provide us a little bit of flexibility for future unforeseen circumstances. Be happy to respond to the safety concerns. You know, just so you know how we make decisions in the Treasurer's Office, we're governed by an investment policy that's overseen by an investment committee. That investment committee includes myself, our Director of Banking. She has over 30 years of experience in state banking, and our Director of Investments, who has, I think, 35 years of experience in the bond and cash management areas. He's also a chartered financial analyst. You know, if you look at that document, that investment policy is online, and our number one principle is safety. So I can absolutely understand your concern. I think it may be helpful just to kind of think about, from a treasurer's perspective, the absolute worst thing that could ever happen would be making a poor decision with the taxpayers' money. So I think there's a huge incentive to not let that happen. And again, there are 2 out of the 4 people, and it would take a majority of the investment committee to make a change, are career employees in the State Treasurer's Office that have been there for over 25 years. So.
Representative McCreary.
Thank you. This is helpful. So there are four folks that sit on that committee, so a majority would be 3?
Yes.
Okay, so 3 out of the 4. And then does the Treasurer's Office have the ability to hire people with specialty expertise? Like, could they work, like the example that the bill sponsor gave was talking about municipal bonds, for example. That's different. I consider that different. We had to get somebody different to help us out rather than our normal financial advisor. So does the Treasurer's Office already have the ability to hire outside experts with expertise?
Absolutely. And you know, we have wide latitude in the areas of banking and investment to bring in whatever kind of help we need. I'll be honest with you, for the municipal bond portion of this, I don't know that we feel like we would need any expertise outside of our Director of Investments. He spent 20 plus years in the muni bond world. But you know, if this let's say that he retires, he takes a well-deserved retirement, and we felt like we did need some extra help, absolutely. We could and we would bring on that help.
Okay. I appreciate that. That gives me some comfort. The other thing is, we all realize just from our own personal finances is sometimes something can look really good at the beginning and then later on it goes south. So, you know, we could face a scenario here in the state where the treasurer has moved on. You know, they've gone back to the private sector, they've moved on to a higher office, and then we're stuck, like, you know, our constituents are actually stuck holding the bag. So that's what I'm trying to get at, is some comfort knowing that there are people with experience, or we could hire folks with experience. So.
Absolutely. And, you know, all this would authorize would be muni bond, the highest rated muni bonds. And it would let us go from 5 years maturity on our essentially federal agency backed debt to 7 years.
Okay.
And that's it, you know, for now. So both of those are pretty safe, I guess, is what I'm saying.
I agree. And then the legislature, maybe if things
Yes.
would go smoothly, then the legislature could open that up to other options, including extending the maturity dates.
Potentially.
Okay. All right. Very good. Thank you.
All right, thank you. Good to see you today.
Good to see you.
Next, do we have a witness in opposition to the HJR? Next witness in favor, please. Are there any other witnesses in favor? Any witnesses for informational purposes only? That will conclude today's hearing on that bill. Thank you, Representative. We will now move back into a public hearing on Representative Gregory's bill. All right, Representative, you'll begin by talking about your sub, and then we'll have witnesses again.
Yeah, that's correct. So thank you, Mr. Chair, for allowing me to, I guess, tee this up again a little bit. So we got another day of testimony on House Bill 2605. We have again got another room full of people that have come from across the state to talk about this important issue. We've heard about the concerns from various stakeholders, and I want to reaffirm my commitment to not capping the wages of nurses and nurse aides. That was never my intent, and that is why in front of you today in the House Committee substitute, we have removed that wage cap requirement. So if you're familiar with the bill from last week, it was basically, I think, the second to the last paragraph. So we're taking that off. That was never my intent, and so that language is gone that has a perceived risk of lowering nurse wages. Additionally, we heard time and time again from facilities that they are solely responsible for any fines incurred because of the overpromises some staffing agencies have made. The language added on page 5 in your House Committee sub, line 43, would be section 198.644, I believe paragraph 12 or section 12, allows for any penalties the facility incurred because of the staffing agency to be passed through to the staffing agency, holding them accountable for their bad actions. So this would mean the civil monetary penalty for staff not showing up, staff not adhering to facility policies, or lack of vetting staff that are utilizing the service to ensure the homes are getting the qualified care that they are hired for. The feedback I received has just not been from nurses who are in opposition to the cap, which this language and the new sub addresses, but from facilities who reaffirm my position on the language. I just had a small group of nursing homes in my office this morning, and I was speaking with them, and I'm sure some of them have visited with you all. And I want you to know that the picture that's being painted by those folks, I asked them, I said, just how dire is this situation? How close are you on the brink of having to close down? And they said, we're right there. And so I asked, well, how have you been getting by? So they're going out and taking out large lines of credit. Some are taking out second mortgages. Some are even pumping in personal dollars into their home, the nursing homes that they own, just to try and keep those doors open, because they don't want to close the door and displace the residents and the staff that have been working for them for years. And so lastly, I talked last time about how this is not a free market industry with my coffee shop analogy. The other economic solution, which is questions I've been asking, is how do we increase the supply of nurses? Because obviously there is a shortage. I've learned that some of the skilled nursing facilities across the state will hire non-licensed individuals, invest their resources and time in training and licensing the individual. But then once that is finished, sadly, that's where some of the agencies will come in and grab these nurses, hire them on for the agency. And so you've got facilities that have paid for all of the training for these nurses and invested in them, and then they're gone. So this scenario is facilities train the staff and are proud of the care that they provide because they've been trained in that home, and so they know what that particular nursing home is looking for in their staff. So this scenario is just feeding more and more people to the agencies. So we have to even the playing field and ultimately protect the residents and their ability to receive high-quality care in a place that they call home. So with that, the House Committee sub is in front of you. The main things is we took out the rate cap and we added in the pass-through liability protections. So with that, I guess we'll go on unless you have any questions.
All right, thanks, Representative. So there's no mention of any more wages or anything like that, capping people's pay of any kind.
That is correct. There is no more rate cap language in the bill.
All right. Further questions for the representative? We will not be voting on this sub today. We'll just take questions for the representative. All right. We will take witnesses in favor and opposition and alternate.
Good evening, Mr. Chairman and members of the committee. My name is Christine Gibson, and I want to thank you for this opportunity to testify in favor of House Bill 2605. I am the Vice President of Business Development for Tiffany Care Centers. We are a third-generation family-owned business that started with my grandmother in 1956. She was an RN taking care of people in her home. And we have continued that tradition of taking care of people in our rural communities since then. We do own and operate 6 skilled facilities in rural communities throughout Missouri. that serve a population base of approximately 67,000 Missourians. During the last 3 years, I've actually been able to be the interim administrator at 3 of our facilities to kind of see firsthand the impact that agency is having on our homes. Agency staffing is a cancer that is slowly killing the long-term care industry, and here is why. My first concern is the financial impact. On average, including payroll taxes and fringes, our wages for CNAs are $18 an hour, LPNs $28, and RNs $36 an hour. Compare that to what we have to pay agency CNAs, $36 an hour, $51 an hour for an LPN, and $65 for an RN. The more critical the need, the price goes up accordingly. Several agency companies actually require a 4 to 8 week contract that guarantees at least 48 hours per week, which means for an RN, 8 hours every week will be paid at $97.57 per hour, which is almost 3 times what we pay our RNs. In 2021, we spent over $617,000 on agency staff. Based on those hours worked by agency, our cost reports will reflect an additional $234,000 in nursing expenses due to using agency versus hiring full-time employees to work those same hours. We try to maintain a competitive wage in our rural communities. However, because the state and federal government dictating what we are paid, there is no feasible way that we can even get close to being competitive with the wages of agency. Which brings me to the second impact agency is having on our facilities. Agency staff inevitably discusses with our employees their flexible schedules and high pay rates. Employees get frustrated because they feel we are willing to pay those larger rates, but we won't pay them the higher rate. We have lost countless employees due to staff recruiting our employees. I have seen firsthand when we submit our staffing requests, within a couple days, those staffing agencies are targeting people in our area through social media recruitment, stating the $20 an hour that they will get paid. I am 100% confident that our staff leave only because of the increase in wage. Just an example, 3 weeks ago, I had a CNA turn in her 2 weeks notice. She, a week after she left, because she went to an agency, she was getting paid $20 an hour. A week later, because of that hole that was left, posting her position on agency, she actually signed up to cover those same exact shifts she just left. The third and the most important is the lack of the consistency of care our residents are receiving. We pay a premium for the staff that we get through agency, and you would expect them to be dependable and professional. However, we find many of our agency staff, they're undependable. They don't show up for shifts. They call in. They aren't committed to providing the same quality of care that we expect from our staff, and they don't like to be held accountable. When we do address resident issues that come up, which we have had them, they just leave and go to another facility, and they don't sign up for shifts at our facility again. I will say we have had some very good staff who have actually expressed interest into coming to work for our facilities. But the buyout is so cost prohibitive that we can't afford to buy out those contracts to get those staff working for us. And the consistent staff is obviously better for all of our residents. The bottom line is the workforce crisis that we are facing is unprecedented, and our dependency on agency is unsustainable. Without this legislation, these agencies will continue to exploit our industry and our residents. While they grow and they thrive financially, the very industry they are supposedly helping, they are actually killing. It's time to act now before facilities like ours in rural communities are impacted, and we won't be there to care for the very people who we have been caring for in our community since 1956. Thank you.
Thank you. Thanks for being here today. To that example where you paid the agency $20, or they got paid $20, that's not what you gave the agency, correct? What would you be paying the agency?
For a CNA, we would be paying them $36 at the lowest, depending on how critical of a need that we're needing.
The CNA or the agency?
The agency. The agency bills us. They send us an invoice, and we pay the agencies
You pay them
directly.
$36 an
We
an
pay
hour,
them $36.
And then they give the CNA $20 an hour.
Correct.
Okay.
Correct.
All right. Questions for the witness, Representative Davidson.
You had mentioned the various rates and the differences in those rates. Typically, when burdens are increased and without a rate cap here in this legislation, that's then passed on to the consumer. Are you at all concerned that this would result in an increased cost because of the regulatory burden put on these agencies?
Would it impact us?
Are you at all concerned with what could be an increased cost that would be passed on through the regulation onto their consumers, which is, yes, ostensibly you?
Yeah, if agency is able to continue to increase their cost to us, it will close doors.
And so given that this legislation doesn't have any rate cap in it, are you concerned with the regulations without a rate cap? Just creating an increased burden?
Yes.
Okay.
Yes. But care is definitely impacted. You know, I always tell my staff that we want our staff to be long-term, because long-term is better for our residents. And the consistent turnover of new agency faces coming into the building, and the training and the policies, it does make it difficult to provide that care.
Yeah.
And the accountability for that.
So from a care and accountability standpoint, you support this legislation, but from a cost standpoint, this legislation maybe creates a more costly environment for you?
Without the cap, it does. I mean, without the cap, if they're able,
Okay.
we find that the more we increase our pay, agency just increases their pay as well. So,
Sure.
Yeah.
And that's what I had suspected, and that's why I asked to clarify.
yes.
Thank you.
All right, thank you. Other questions for the witness? Thank you. Thank you for being here today.
Alrighty, thank you very much.
We'll take a witness in opposition to the bill.
Good evening, Chairman and members of the committee. My name is Dave Barmore, and I'm Head of Government Affairs for ShiftKey. I am here before you today in opposition to the bill. ShiftKey was founded in 2016, and it is a digital platform enabling nurses and other healthcare professionals to seamlessly connect with facilities to help fill empty shifts. We help facilitate a two-sided marketplace. On one side, we have facilities who are in need of temporary healthcare workers who can post open shifts. On the flip side, we have the providers, nurses and other healthcare professionals who can view and select those shifts and then set their own rates. We partner with hundreds of facilities across the state, both in rural and urban settings. And in partnership, we've helped fill over 250,000 shifts, with nearly 4,000 healthcare professionals looking to find flexible and independent work. Of that 4,000 workers, nearly 800 of them have come from out of state to help support Missouri residents. Given the overwhelming nursing shortage that Missouri is currently facing, ShiftKey can help provide a solution by bringing in more healthcare professionals. And the way we do this is by offering them the ability to work on their own terms. So that's where they want, when they want, and how often they want, and being able to set their own rates. On the flip side, we also help facilities with the immediate need of filling shifts not being taken by their full-time staff, so they can focus on what's most important, which is providing quality care to their patients. By providing a true marketplace for posting and finding open shifts, as well as verifying credentials, conducting background checks, and more, we provide a frictionless process, making it simple for facilities and providers to connect. Before I touch on some of our concerns with the legislation, I do want to take some time to correct the record on some of the false claims that were made during last week's committee hearing. First off, we do not sign non-competes with our nurses and facilities. If a facility does choose to hire one of our professionals, there may be a placement fee imposed, but I think it's important to stress that that is a rare occurrence. And in the past year alone, we've only had to place one of those fees with the facilities. Second, we never recruit full-time staff away from nursing homes. We've never called a facility to recruit nurses or other professionals. Nurses find us largely through digital marketing and by word of mouth. Our relationship with facilities is absolutely critical, and we would never enter into a practice that would harm those relationships. We ensure that nurses on the platform are properly certified and credentialed based on the needs of the shift that they are looking to fill. Facilities post the shifts based on the specialty that they need, and only providers who are licensed can choose to elect into those shifts. Importantly, we provide access to occupational accident insurance and medical malpractice coverage that applies to all of our providers while on a shift that they've booked using our platform. We heard a lot about bad actors on the platform. If there are ever any issues with a bad actor, I think it's important to note that the facility can flag those incidents with our red flag or a do not return designation. Consistent with our own terms of service, if there are habitual offenders, we'll flag those and potentially suspend those providers from having access to the platform. And just want to take a second to explain a little bit more about how the platform actually works so you can have a better appreciation for how this provides the utmost flexibility for not only the workers, but also the facilities itself. Nurses can view open shifts and can bid on that shift within the pay rate that they would like to receive. We believe in empowering these heroes to set their own rates. On the flip side, facilities have fixed rates with ShiftKey. No surprises, no fluctuations. There are shift rates and premium rates for the shifts that are harder to fill. All of this is determined with the facilities during the contracting process. It is 100% transparent. Based on the rates of the facility, there is a range of pay that are available for the nurses to bid on. This protects the providers by not allowing the process of undercutting or a race to the bottom. And for facilities, it protects them by not allowing for exorbitant rates to be had or any gaming of the system to occur. If a facility is able to cover a shift with one of their full-time employees, they can cancel without penalty. So on the legislation before you, we have some serious concerns. With the pay cap aside, there are still issues that remain, namely with the fact that it would mandate that all workers with these platforms be full-time employees. That does nothing to address, like I said, what I think the long-term solution is here, which is bringing more people into the field. So we need to find ways in which we're able to help expand that pool of workforce, and I think tools like ShiftKey can help do that. So we are here. We want to have a conversation, but I think it's important to know that unfortunately is a non-starter, and we want to find ways, like I said, where we can work to broaden that out to make sure that we can provide access to care for as many Missourians as possible. So with that, I'll take any questions.
Thank you. Thanks for being here today. Representative Hafner.
To inquire, Mr. Chairman.
Please proceed.
Gentlemen, good morning. Good evening. Glad that you're here, and I appreciate the bill sponsor. I do want to say publicly, I appreciate the work that you're doing and working through all these issues. And so we've talked about a couple things, and I know that you mentioned some of these. I just want to go on the record as mentioning these. From a wife who has worked as a nurse for 36, 37 years, she's been on both sides of this, full-time in the hospital, as well as being working with an organization such as yours. And I appreciate, gentlemen, you working and removing the cap. I think that was crucial to the bill, and I think we can work some other areas in that as well. I am still concerned about some of the administration in there because the companies are handled very differently, and I'm not the expert. I'm going to look to some of the other people that are here. Because the companies are structured differently, I'm not sure that the administration is appropriate. And I think that we need to bring some parties together in order to resolve that. I'm too very concerned about the independent contractor language that's listed in here. I think from a workforce management, I think that's crucial to keeping the individuals engaged with the shortage of medical personnel that we have. And I'd like to continue to work with you on that. And the key is this is the accountability side without being overburdensome on the administrative side. So to the bill sponsor, again, thank you for what you're doing on this. I just want to continue to engage in some conversations. Thank you very much.
Great. Thank you. Representative Ani.
Thank you. To inquire.
Proceed.
And apologies, my foam keeps falling off. So thank you for being here. I heard you say, talking about ShiftKey's business model, and it sounds like you guys want to make sure that the folks who work for you, or however you want to phrase it, as contractors, they're able to work when they want, where they want, how they want, and they can choose their rate. I happen to agree that this is a fantastic business model because it's the same model that I have on my business. I own a virtual marketing agency, and I only employ contractors. And they are able to set their rates. They're able to decide when they work, how they work, what clients they want to work on. But we operate in a free market. When we're talking about Medicaid reimbursements and caps on what we're able to actually reimburse for costs of care, we are not in a free market. So that's one of my biggest concerns here. I also want to talk a little bit about some of the claims that you made of people's testimonies being false last week. We were actually given some testimonies of folks who have worked with ShiftKey employees, and I'd like to just read you a few of the examples of the feedback we've gotten. ShiftKey nurses are notorious in our building for subpar documentation, incomplete documentation, or the documentation isn't done at all. Another one is, we contracted to start using ShiftKey back in October. However, to date, we haven't had any nurses sign up to work at our community because we never select the premium shift option. We've been told by other facilities that their nurses will only accept shifts if you mark them as premium. It depends on the staff, but 9 out of 10 ShiftKey employees are late by at least a half hour or more for their shifts, especially on the weekends. Administrators and DONs have witnessed numerous weekends where the weekend option managers are forced to spend the entire first 2 hours of each shift calling ShiftKey nurses and CNAs to inquire about arrival times. We are lucky if they answer once they are late. Those are just a few. So my question is, you can sit up here and tell us that that's not happening, but we're hearing firsthand from these facilities that it is happening. So this is clearly a problem, and that's kind of why we're here to address the issue and figure out exactly how to do so. My question is, what is the point of premium rates if your folks aren't even going to select an option of not a premium rate? Why have that on there, especially when we're talking about facilities that are strapped for cash flow? Why do that?
Thanks for the question. I'm sorry to hear some of those experiences with ShiftKey. I think we've heard from some facilities across the state that have had very positive experiences, and we've tried to see if we can't help amplify some of those testimonials as well. I think it's important for you to hear that there are facilities out there in the state that are very pleased with our partnership and have found the providers through our platform to be very helpful. On the premium rates, all I can say is my understanding is setting up the difference in rates, that's all negotiated with the facility when we're working through the contract, and we set up those different rates to try to prevent those instances from happening. So happy to continue the conversation to see what else we could potentially work on to minimize those occurrences. But that's all I can say on that. Back to the first point you made on with some facilities having heavily regulated markets with the Medicare and Medicaid reimbursements. I think it's important, again, to state that the facilities have full control over the rates that they set, and they should factor in whether or not they have those reimbursement rates. That should be a factor in when they're setting those different rates with us on the front end. So,
Right, but if no one will accept a lower rate, these essentially don't have a choice but to increase what they're willing to offer, correct?
again, I would want to see what more we could potentially work on to minimize those occurrences from happening. But the way that we have it structured now, we feel that is best to try to minimize that from happening. So.
Okay, and do you offer any incentives to employees who refer new employees?
I believe in some markets we do. I would have to check on Missouri if we have any of those incentives.
Okay, so would you not consider that recruiting then?
I would need to check on that, whether or not we have that any currently in place in the state. So I'll have to get back to you on that.
Okay, thank you.
Representative Davidson.
Could you speak to, and I think you had mentioned it before, can you speak to what sort of liability insurance you hold or carry pertaining to these nursing homes?
Yes,
and your employees?
absolutely. So we have two towers of policies, if you will. So one is that occupational accident coverage that the providers elect into with every shift that they work through our platform. So they have that coverage up to $1 million per incident. And then in addition to the occupational accident insurance, they also have access to the medical malpractice insurance as well. So
Has there been I mean, even a ballpark number? I'm not expecting it, but I'd like to have a sense of a number of like the civil damages or damages paid out and throughout the time period that you all have done business in Missouri in regards to your contracted employees in these nursing homes. Do you have a sense of sort of of damages that have been paid over the last 2 years or year?
I don't. I could check to see if that's something that we'd be comfortable sharing, but I would need to check with our team on that.
Thank you.
Representative McCreary.
Just a point of clarification. So you said that your employees have access to that insurance. Does that mean they have to opt into it and pay for it? Or does it automatically happen every shift that everybody you send out into a facility that they automatically have that coverage?
So through the independent contractor model, we cannot provide that coverage, but they have access to those different policies. And they elect into that when they're on the platform.
So they have to purchase it on their own and expense it on their own?
They take a portion of their earnings through the shift key, and that goes towards those policies.
Are they required to carry it?
I believe so, yes.
Okay. Can we make sure?
Yes.
Okay. Representative Fogel, did you have a question?
Yes, thank you. Just trying to get to the heart of some of this objectively. So you said earlier that the recourse for agencies or for facilities, if they have an employee that's not performing to the expectation that they lay out, is that through the app or the platform they can red flag or mark them as do not return. Do you have information on how many instances of that have occurred through Shift Key over the last year?
In terms of how many providers have received those designations on the platform?
So is it the provider side? When you say provider, you mean the nurse?
Sorry, the nurses.
Yes. Yeah, that's what I'm asking. We're hearing kind of two conflicting sides of this, that there are a lot of problems with these nurses or CNAs, and then the other side saying that this problem doesn't really exist. So I'm trying to get to the heart of it objectively. And I think one of the best ways of doing that would be how many times do we have documented that these agencies are saying we don't want these nurses to come into their facility? So do you have any hard data on what that looks like? How many red flags have been flagged? How many people have been asked not to return to facilities?
I don't have any data on the number of nurses that have received those designations, but I do think it's important to note that facilities have the ability to see whether or not the nurses have those tags when they're deciding to accept the shift request.
Okay, so if somebody if I'm a nurse on your platform and a facility had marked me as a red flag or do not return, another agency could go in and still request that person, or that same agency could go in and request that person, even though they had that designation.
That is my understanding, yes.
We don't know how many total red flags or total do not return we have.
I don't. I could see if, again, that's something that we're willing to share, if we're able to share that publicly, and I can get back to you on that.
Okay, that would be helpful. Thank you.
What makes a shift a premium pay? I just downloaded your app, so I'm just looking at what makes it premium. How do you decide that?
My understanding is that's something that we work with the facility. Those premium rates are typically for shifts that are more difficult to fill. So that's something I think, again, we negotiate
kind of
with
the market. If they can't fill it, then you can raise the price on that.
Again, I believe that's something we work with the facility to understand what are those types of shifts that we want to offer up under that premium rate.
Yeah, because I think if the premium pay was because the job is harder or there's something more acute about it, that would be one thing. But if it's just, we know they don't have anybody, so now we're going to do that, I think that is what makes people not like this and get uncomfortable. And then the button here says start bidding on shifts. Does the CNA bid, what is that? They push the button, start bidding on shifts. What happens?
You see all the available open shifts that you're eligible for based on your credentialing and licenses.
Okay, so then it'll show you the ones in the area, and then do you bid on that? Like you say, I'd like to go here, and then you have to.
You can set a rate that's within a range of what.
Then you set your rate that you want to make.
The nurse does, yes.
Okay. All right, thank you. Any other questions for the witness? Representative Ritchie.
I'm kind of, as I'm listening, I apologize I came in late. I had 2 other hearings going simultaneously in addition to this one. So this is the first time I'm actually seeing the committee substitute language, and I don't know that you've seen it, but a part of this is to close the door on independent contractors. So 1099s would be deleted. They would go away. On my first reading, that may not be accurate, but I think I'm reading that correctly. Can you speak to the value or the benefit, the upside of maintaining a 1099 approach as opposed to actually hiring individuals as employees? Because you guys, we're talking about employees. Technically, you don't have employees that are filling these shifts. They're independent contractors. They freely engage you or don't engage you. What is the upside from a business model for maintaining a 1099?
Thank you for the question. As I stated, that's our main concern with the new language that we just received as well. And to be clear, that would force us to leave the state. We would not be able to operate our current model under those kinds of conditions. And I can't express how we just think that is a misguided approach, given that, again, it would shrink the overall size of the workforce that would be coming in. Those 800 nurses that we had coming in from out of state, that is the flexibility of the market allows us to do that, and that's what we need to maintain. And that's you can hear that from me. I think it's even better to hear those from the nurses, and we've been trying to see if we can't have some nurses that value this kind of flexible, independent work come and tell you themselves. And I hope we're able to have some, if not today, contact you and relay their testimonials again as to how they really value this kind of independent work. So we see it as a critical piece in this and something that, again, I think is very important to not only the nurses but the facilities as well.
Okay. Well, I've found myself throughout the years in a 1099 situation. And I think, and I'll have to go back and check again. It would have been nice if I could have seen this, but then again, I don't think we're voting on this today. So if we are, I'm not prepared to do so. But the statutorily, I think there is a definition of what a person who meets the statutory definition of an employee. There's certain factors that have to be in place. Things like they are accountable to hours that you set for them. There are deadlines that you establish that they have responsibilities to, as far as project management issues and a few other things. I'm kind of going off of a fuzzy memory here. As a 1099 myself, I had the ability to pick and choose, and no one told me I had to do anything. I basically said, I will take that and I will work within the context of the defined responsibilities as an independent contractor. And it seems to me if we were to put any entity, ShiftKey or otherwise, because this obviously is broader than you guys, in a situation where you had to hire these individuals, then these individuals would no longer be utilizing an app where they can pick and choose, because you would be dictating to them, you're going to show up here on Tuesday, you're going to work a shift of 8 hours, and then on Wednesday you're going to go down the road to this facility, and you would be more directing their time in order to meet the definition statutorily of what an employee-employer relationship typically is. Is that somewhat consistent with your experience in Missouri, outside of Missouri, in terms of those discussions on what business model works best for this context, whether it's a 1099 or an employee hire?
And to be clear, we do not operate, we operate in over 30 states in the country, and in every state we maintain that independent contractor relationship. That is, again, what allows this to work and allows us to be additive to the overall healthcare system. And so we do not operate anywhere that has that W-2 relationship codified.
Okay, a couple of questions then that that I think would be helpful for us as we're thinking about the broader challenges that we're facing. Would you say that it is in ShiftKey, because that's the only entity you're here to talk about, is the one you work for? Would you say that it is in your best interest as your business model to have a high degree of customer satisfaction in terms of the facilities you're serving?
100%. Like I said, we are a two-sided marketplace. Our customers are not only the nurses, but the facilities. And that's why we want to ensure that facilities are having a great experience with us. And so, yes, 100%.
Okay. And then, do you believe yourselves, again, we're all kind of taking testimony in terms of the anecdotal evidence on both sides of the issue, both from nurses and medical professionals that want these options to be left alone, and facilities that are crying out, significantly for some relief, because it's, bringing this crushing weight of cost upon them. The stories that we're hearing from both sides, and I honestly, I don't know, I don't have any reason to not believe what's being said. Otherwise, I would be saying that they're lying to us. But assuming that everyone's, speaking honestly, how do you believe ShiftKey in the context of Missouri, how would you describe your responsiveness to the concerns that have been voiced to us in terms of lack of quality, no-shows, inadequate certification, proof of certification, licensure, what have you? This is your opportunity to kind of testify to the fact that we've been very responsive. We've had some concerns raised. We've addressed those. Or, you know what, we really haven't had the kind of formal communication coming from our clients to the degree that seems to be communicated to us as a committee. Long question, but hopefully there's some clarity there.
No. Absolutely. We want to have a dialogue, and it's important to us to receive this feedback to see if maybe there are ways in which we can refine the business model, other designations that we can help ensure that we are providing the access to the best nurses and healthcare professionals on the platform. So always want to have that open dialogue with the facilities on ways in which we can potentially improve. But I do think it's important, and that's why we're working to make sure that facilities that have had those really positive experiences. I've been on email threads with facilities that have proactively reached out to say how pleased they are with certain nurses that have just gone above and beyond. So I also want to make sure you're hearing those stories as well, not only from the facilities, but from the nurses. But we're here, we want to have a dialogue and see, what ways in which we can, we're always open to improvement as well.
Okay, and then the last question that I'll have for you, it seems like, for instance, on the examples that were given in terms of medical professionals, because I don't know if they're nurses, LPNs, CNAs, or whatever, in some of the testimony that we received in written form, saying that no one will take shifts unless they're premium shifts. Would you say that that's more of an indication that the user of the app is just simply not willing? I mean, that's kind of their choice, right? I mean, it's not that. I mean, if I'm understanding the app correctly, if I happen to be a CNA and I'm on your app and shifts are coming up, it's not like you're telling me not to take shifts unless they're premium. I'm just making the choice. Unless it's premium because I'm going to be able to make more money, I'm just not going to be interested. That's more of a personal choice on the user, on the part of the user, right? I mean, or is there a different mechanism that I'm not aware of that would kind of lead people to say, systemically, no one is interested because of a system issue? They will not take shifts unless they're premium. Is it more individual based, or is there some kind of a mechanism in your app that drives them to that conclusion?
I'd want to look into this, but I think it's important to note that, again, nurses bid on the shifts, but it's ultimately up to the facility to accept those shifts. So, but it's something I want to look into and get back to you, as I know it's been raised by a number of the committee members.
Okay. It just seems to me that on your particular, because I think that there's some agencies that I've not yet had an opportunity to engage that seem to be more in the category of operating problematically than what I've actually seen in front of me in terms of you guys. And I don't know you guys from Adam. I mean, I've never even encountered ShiftKey because I'm not in the industry. So I had a nursing home group describe a situation not too long ago where they were in desperate need. They ran across a nurse through an agency service, and in order to hire her, they had to pay $22,000. Has that ever happened with ShiftKey, to pay you $22,000 to buy out a nurse to come on board?
As I said in my testimony, we have only had within the past year one instance where we've required that fee be charged for a facility that chose to hire one of our professionals.
Someone showed me one of the contracts you guys have that people sign when they come on board or whatever it is. The fees that I saw there were nowhere close to $22,000.
My understanding is those rates vary based on the market, but yes, they're nowhere near what I.
Well, to be clear, that nursing home group told me it was not you guys. So, all right. Well, I will be quiet at this point, and I appreciate the opportunity to ask these questions of you. Thank you.
Further questions? All right. Thank you, sir. Thanks for being here today. Thanks for flying in.
Appreciate it.
Next witness in favor of the bill.
Hi. It's a little hard for me to follow that because I am a nursing home owner and I have prepared a statement. So I'm going to read my statement, but I can also provide what I've seen in our homes, anecdotal evidence from what we've seen from different agencies. So,
And ma'am, can you remember to introduce yourself?
Sure.
Thanks.
Yeah. So my name's Gina Giardino Wiener, and I'm a second-generation nursing home owner. My father, Jim, grew up in St. Louis. His father was a taxi driver, and his mother stayed at home to raise her children. He began cutting the grass at a nursing home when he was 15 years old. By the age of 19, he worked his way up and became the youngest person in the state of Missouri to receive his administrator's license. He met my mother in 1978 at a Knights of Columbus dance, got married, and began a family. By the time I came along in the 1980s, he was an owner-operator of several homes in Missouri. The home office was in the basement of one of our nursing homes. With my mom having her administrator's license and working in the family business alongside my dad, sometimes they would send me upstairs. There was an occupational therapist named Lucille upstairs, who was one of the sweetest, kindest person you could ever meet. Some of my earliest childhood memories around the age of 3 are running the halls of that nursing home and Lucille chasing after me in her sweet voice. You can imagine how much nursing homes mean to me and my family. They are in our blood, part of our identity, and have helped shape the people we are today. The past 2 years with the COVID-19 pandemic, we have seen some of the most difficult years in the business. Long-term care workers are leaving this industry at an alarming rate. Since the pandemic began nationwide, over 420,000 employees have left the business altogether. It's becoming harder and harder to find employees. Over 90% of my family's business is in rural Missouri. We are a service business helping to take care of geriatrics in these communities. We have a purpose and we are serving a need. The agencies see an opportunity in Missouri. We are a conservative state who like free enterprise. I understand that, but I also understand that it is not as black and white as that. We are working with a set rate of reimbursements from Medicaid and Medicare. So unlike the agencies, we cannot continue to raise wages. We are asking to help regulate the agencies and level the playing field for us. I have seen firsthand the impact agency has had in the state. Of course, the financial impact, which most people see first. Our business has seen agency increase 5 times since the COVID-19 pandemic began compared to pre-pandemic usage. But there are 3 other key points which are equally as important. 1, quality of care. In 2 of our nursing homes, we have been cited for IJ tags. In both cases, they were agency employees, actually shift key agency employees. Who is responsible for the incident and the fine? Who takes the hit on the star rating, and who suffers the most? It's not the agency, but it is the nursing home itself, and it is the resident. 2, continuum of care. Do I know who I'm taking care of, how to take care of them, and how does this resident respond best? Daily employees know this about their residents, and families feel safe seeing the same people caring for their loved ones. 3, employee engagement, which has 2 components. The first component is the engagement of an agency employee. We do not know the attitude or skill set of who is coming into our building. All that we know is that an employee is needed for that day, for that shift. Who is going to be sent? What is their attitude? Are they a team player? The second component is the engagement of a nursing home full-time employee. Frontline healthcare workers who are dedicated to the tough but rewarding nursing home business. They are now second-guessing themselves. Should I go to agency? I can make 2 or 3 times as much doing the same job. These are our decisions our employees are confronted with. We cannot blame them for having this thought. We are putting them in a position to decide, should I stay at a place that I know and love, or should I move to agency to make more money and better provide for my family? However, you as legislators can support these hardworking Missourians who are essential and who have showed up the entire pandemic by regulating the agency in our state and leveling the playing field. I was fortunate enough to attend college on the East Coast. As a young Catholic Midwesterner who spent a lot of her life in rural Missouri, I surprised my parents and met a nice Jewish young man from New York. You might be wondering what this has to do with tonight. When we were planning our wedding, his family wanted a rabbi and my family wanted a priest. A compromise? A Pentecostal minister, Lucille's husband. So yes, that occupational therapist that would watch me run the halls as a child and showed me so much love, her husband officiated my marriage and they were guests at my wedding. These are the kind of relationships that nursing homes bring and are built after years and years of working alongside one another. Please support your hardworking Missourians and their families and vote yes on this bill. Thank you.
Thank you. Questions for the witness?
Yes.
Representative Ani.
Thank you. To inquire briefly, if you could, would you talk a little bit about if a bill like this doesn't get passed? If we don't solve this problem or work towards solving this problem legislatively, what effect is that going to have on your business?
I look at it as an effect on the community, and I see us in our nursing homes in these rural towns. Like we have a couple homes in Salem, a res care in Salem, skilled nursing in Salem. And if we continue to have the agencies move into our rural markets, and we don't raise our wages, and they go to larger cities. They drive an extra hour and go to Rolla, or they go to Springfield. And so instead of having, mom or dad down the road in their community and serving their same people, we're not serving that. There still is a need in these rural towns, and we're driving people out of them and forcing them to go to larger cities. So, the overall impact in the nursing home community is just sad. It's heartbreaking. We have some really good employees who they have to drive a long way anyway to come to work each day or to see someone, and to make that much further for them to go, or to make their family member that much further. Like we're operating in smaller demographics where they all know each other. Like they know the CNAs, they know the staff there, and it's just a disservice to Missouri.
All right, thank you. Thanks for being here today. Next witness in opposition to the bill. Oh, Representative Fitzwater.
Yeah, really quick, sorry.
It's okay.
You mentioned that you had a couple discrepancies with the last testimony before you read your sheet. Can you mention one or two of those?
Sure.
That personal experience?
Yeah, so a couple of them. I don't think that agency has everyone's best interest at heart. Like if I was in this business just to make money, then I would just go start my own agency. But instead, since this is something that's generationally been in our family and I've grown up around, is that I see it from like our residents' point of view, and I see it from our employees' point of view. And it's not the employees' point of view. Like, it's not their fault wanting to go to agency. They're just trying to provide for their family. And you have an agency which is like, basically it's an unregulated digital platform that they're not counted as employees. Like, they're just a 1099 contractor on there. They get no benefits, and the people who are signing up for this, they don't really want to leave their community. These are good employees. Like, they want to stay in the nursing home because, like, this is their support system, this is their family, and we're kind of making them choose, like, to go somewhere else, okay? And by doing that, like for instance, I had a CNA the other day who was like crying because she didn't realize, when they sign up, they don't realize, they just see a paycheck and they're living paycheck to paycheck, and they see that increase and they're like, wow, I'm making this much more per hour, like how awesome, and then they go and spend it. And now we're back in tax season, and like they didn't realize they had to file their taxes, and they're like in tears, like, oh my God, like I thought I made all this money last year. I didn't know it wasn't taken out of my paycheck. I don't get benefits. Like, it's heartbreaking because like they're good people and they have good hearts, and being in a nursing home is a tough job. It's not an easy job. And the job market is, so competitive that we keep raising our rates as much as we can, but, there are other jobs out there that, for instance, an hourly job at a grocery store or something that's different. So it's like, it's hard to stay competitive, but like, it's hard for me when he's talking and saying like, oh, I have everyone's best interest at heart. Like, I have the owner's interest at heart. I have the nurse's interest at heart. Like, I don't feel that at all. And I don't see, how that's possible, with some of the things. Like, I talk about the 2 IJs that we got. One of them was, they were both with Shift Key, and one was CPR certification. And we got an immediate jeopardy tag, which is the strongest tag you can get when a state surveyor comes in. And they came in, and it was 22 months of them not coming in. We had a brand new LPN administrator from the town. She's working her tail off. She's got kids. She's working evenings. She's got a family, and she's there, like, taking care of our residents. And she's stressed out, and they're asking about the CPR certification, and she asked about some of our agency staff CPR certification. So, of course, we go and get it, and it's a piece of paper. And they're CPR certified, but because Shift Key isn't really, and I don't want to pick on Shift Key, but this is just my experience, is that they're not from the state of Missouri, and so they see an opportunity here. And you have to really, when you do CPR, everyone in the nursing home has to go through in-person training, whether it's COVID or not. An online CPR certification doesn't count. And so we got cited for that, and we were the ones who, you know, had to complete the plan of corrections, had to submit it, get the fines, and then that hurts our reputation in our community, like these good working employees who, like, I think of the young administrator there, like, she's giving up evenings with her kids to, like, help do dinner and sleep there, and then she's cited on this, and she's stressed out, and it's just not a helpful situation for these communities and for our employees and for the residents and even for the residents' families. Like, they love going in a building and knowing the housekeepers and dietary, and it very much is a community. I don't know how much time you guys have spent in there, but it feels like a larger family. And so, you know, these experiences are hard. And the other IJ I had was at another nursing home. It was an evening nurse, which evening nurses are that premium pay he's talking about. And you don't have a choice because you have to have an RN in the building. So we have to pay the premium rate to get the RN. And there might be 4 other buildings that need that, and maybe the other building doesn't pay it, or you've got another RN who's going to work that double and not stay and not go see their family. So we take that premium pay, they come in, and she didn't give someone insulin. Of course, it's our fault as owners, so we do a self-report, come out. She walked out on the floor. And we said, what can we do about this? Sure, we can report her to our building for that specific building. We had a nurse walk out, but there's no liability for the agency, and we might be able to hit a button, but then the nursing home 10 miles down the road or 20 miles can still pick up that same nurse who walked out and didn't give that insulin. I mean, it's a faulty system.
Did you have a question? Representative Davidson.
I had asked this question earlier in the committee. I was wondering, do you think that some of these additional compliance and regulations here, is there any concern at all for you? I mean, the thrust of your testimony has been more about the health care provided. But is there any concern at all that these costs would be passed on to you? The costs that would inevitably...
Yeah, I think the way that I look at it is, like, when I'm talking about, like, for me, I think there's 4 main points that I made. And the first point is the financial. But there's 3 other key points that we're talking about in a nursing home that, in my opinion, not everyone's opinion, but in my opinion, are equally as important. Those other 3 points are the quality of care, the continuum of care, and then the employee engagement. And so it's not a concern for me because can I have 3/4 of those, or
so you'd be willing to pay more so long as you can maintain a higher quality of care, you know, the other things that you bring up?
Yeah, I think that I would like to see some regulation for the agencies, because right now there's none.
Yeah.
So whatever that means, like, is it perfect? No. You know, but I think it's something that we're willing to make some ground on, because right now we have nothing. So we need something.
Yeah, and I'm just trying to think, how do you keep things cost effective? Because one of the chief concerns has been how cost prohibitive these agencies have been, and that's the real damage to the industry, even more so than healthcare. But I think we're on the right track, so I do appreciate your testimony. Thank you.
Thank you. And Representative, I think what you're saying is you're increasing regulations on Shift Key. They're just going to pass those costs back onto you. Is that what you're saying?
That's the concern, that maybe we're not addressing the cost issue.
Yeah.
But you did hear him say if there's more regulation in agency, he'll leave the state of Missouri. Didn't he say that, or did I hear that wrong?
I do recall him saying something to that effect.
He said that. So this is an opportunistic agency who's coming in like this digital marketing space. So my idea, or I don't know for sure, but I'm saying if it's more regulated and you're saying you have to hire these people as employees, like, these are good rural, like, Missourians, like, give them the opportunity to help with benefits or payroll taxes, you know, or taxes in general, like that.
Would you rather have maybe a subpar agency CNA that costs more, or no CNA at all?
The park, that's regulated more, you mean?
No, not regulated more. I mean, if the ultimatum that we're kind of faced with here is either having serious shortages, right, or
in our
or
communities,
an expensive cost.
Yeah, like in our communities, I think that, so we have these really strong communities, and when you have the agency, so we've got a lot of shift covering. And then as owners, we offer a shift difference, or we offer a bonus, but these people are friends. And so if I'm in the building and I'm like, hey, you know, like Representative Hicks, for instance, like, hey, like you work your evening shift for me, then you want to go out Friday, I'll switch this shift. And they work together, you know, they work together more to cover each other's shift.
Yeah.
So that's what, you know, when you have that in the community. Once you get the agency in there, we do see the agency. They're late, they don't show up. I've worked the floor before, you know, in a nursing home that had COVID, that had, this is during the pandemic, we had no one show up. And I've worked with agency nurses, and I sat on it for a few days because I was like, wow, I don't want to go to work every day with someone. If she's going to treat me like that as an owner, how is she going to treat the other CNAs? How is she going to treat the nurses? How is she going to treat my resident? You know, I mean, that's what we're faced with.
Yeah, and again, I think we're splitting up into different categories. I'm trying to keep some sort of focus on the costs here, but I do appreciate your testimony, and I'm not alienated from it. I've got a dad who is a CNA, a brother who is CNA for many years, so I'm familiar with the world that you're working in, the challenges that you all face. So I appreciate that.
Representative Ritchie, and then we'll take the next witness.
Okay. Thank you, Mr. Chair.
Ma'am, he's got a question for you.
Yeah. No, that's fine.
I'm sorry.
Yeah. No,
Star witness.
I definitely feel for your situation. You guys, I mean, you're in a real pickle, and I feel for that. And I'm trying to think through kind of the solutions that haven't really been discussed yet. Is it so when you guys hire a nurse or a CNA, you physically collect documents from that person in the hiring process to verify that they are certified and properly licensed and everything else?
Absolutely.
Why would it not be possible in either the contractual negotiations or the flat expectations, if you're going to come into my facility and serve my residents as a nurse, you're going to walk in with all the proper documentation so that we can get a copy of that and keep it on file for you?
It's just, I think we've got to be realistic in the expectation of what's happening in a nursing home. And so we've had COVID-19. There's a lot of extra screening regulations. You used to be able to walk in and out of a nursing home. Like, we've got to go into a nursing home. We have to fill out a whole form. We have to ask people when they were vaccinated. Have they been exposed to COVID-19? I mean, we have to have a person doing that. We have to make sure they're properly fitted in PPE. We have to, there's a lot more that has gone in to being in a nursing home right now. And especially on like a Saturday morning, for instance, you don't have your regular DON or administrator in the building. For them, it's just unrealistic. For us, we're trying to juggle a bunch of balls. And let's say we're a 24/7 business. It's not like we turn the key at 7 a.m. and we get to open up.
I mean, that wouldn't be my assumption in the first place.
No, I'm just saying that it's hard. It's hard to have that high expectation of trying to fill a shift and then also trying to collect all of the proper documentation.
So this would be my assumption based on like the regional areas that, you know, smaller communities, as you were describing yourself in, the people that are filling shifts with any kind of agency, you know, whether shift key or otherwise, that I wouldn't imagine that you have, you know, 90 different faces that you never see again coming through to fill these shifts. They're probably people that you're seeing that are fairly regular because you have staffing shortages. So it just seems to me like, in spite of all the COVID stuff, whatever, that it would, I mean, if I were a nurse and, you know, I'm working, a job, a full-time job somewhere, but I'm trying to pick up extra shifts somewhere, I would want the opportunity to operate in a 1099 category so that I can pick up shifts here and there as it would fit my schedule. And I don't know that it would be an imposition on me whatsoever to say, when I walk into your care facility, you're going to have an expectation that I'm going to have a packet showing my certifications. I mean, I don't know that any nurse would say that's unrealistic to expect me to verify that I am who I say I am. You guys get the copies and then it's all good. Now you're covered. If you've got someone that shows up and they don't have proper documentation, then you're at that point saying, hey, listen, you guys sent us somebody that's not qualified, and they're not even being allowed to operate. So I don't know. To me, that seems like that would be more than reasonable.
I see what you're saying, and it sounds like it would be reasonable, but you have to keep in mind that we're contracting with an agency, and then we're paying double. So we're paying double cost for that shift. So why should that burden be on us?
Well,
Like, why is, what I'm saying, why is it not on the agency to make sure that their nurses or CNAs are properly vetted and properly trained? Like, we're paying double for that, and we're in a bind. We're obviously, someone didn't show up for their shift, and we have to be staffed to a certain, patient per day, and, so it's.
I got you. That's
the way I look at it, but I see how you could look at it that way, but I don't know how realistic that is for a nursing home.
I can see your position that maybe we shouldn't have that responsibility. But I for people that are seeing this as a tremendous benefit to them personally, as you stated, trying to cover the needs of their families, I don't know that anybody would throw a fit, say, how dare you ask me for my certification and licensure details so that I can actually come in and practice medicine for the benefit of residents. And then on the continuity of care issue, I don't know that anybody would be able to really take responsibility for continuity of care issues when it comes to what you were describing and others have described on. It's always better if you have the same face for that resident. Absolutely. But it's not the fault of an agency, nor is it your fault that right now, industry-wide, we're having a staffing shortage, right? So there's a sense in which you guys have a tremendous benefit in that you have a tool at your disposal to bring staff, like temporary staff in to fill shortages, but to turn around and then identify that they are a source of a problem for lack of continuity of care. I mean, they're providing coverage at a point where we don't have enough staff to cover.
Yeah,
right?
I think that I think we're coming from really different perspectives.
Okay.
On some of that.
I'm not really sure what perspective I'm coming from, quite frankly.
Yeah, I think that you're probably more business oriented and not like in the, I don't know, healthcare sector maybe.
Yeah. Okay, well, that's fine.
No, but it makes.
Yeah.
I understand your questions and.
Yeah, I got you. That's
Okay.
fine.
Thank
All
you.
right, thank you. Appreciate it.
Thank you, ma'am. We're going to move on to further testimony. We're going to start shortening the testimony. If you have exactly the same testimony as someone else, you can submit your testimony in writing, and we will read it, and then you don't have to come up here and read off anything. Next witness in favor or in opposition to the bill. Do we have any more people in opposition to the bill? And if you could give us some quick testimony, ma'am, that'd be great. Thanks. We're going to start wrapping up.
Thank you for allowing me to come and talk to you. My name is Michelle Hall. I own a local nurse-owned staffing agency in Southwest Missouri. So I think I can bring a little bit more to the table and maybe be able to answer some of your questions. I will focus on most of my testimony on some of the questions you guys had last week that I don't feel like got answered, if that's okay.
Please, thank you.
Okay. So last week, it was mentioned that there's no one responsible for agency nurses who perform subpar work. As a nursing staffing agency, the contract that I have with every one of my facilities require me to maintain general liability and medical malpractice on every single one of my coworkers. My coworkers are not 1099, they are W-2, they work for me, I provide them benefits. So I actually work with my facilities. When they have issues with one of my coworkers, I write them up just like they were working for any other facility. And if they are not working at the level that we want them to be, they are no longer working for our agency. An example is I had one nurse who no called, no showed. On a Thursday, on Friday, they were no longer working for me. And that is how agencies should be running. Staffing agencies are changing the rates on facilities, and they are forced to pay them. Charges for nursing staff sent to it by an agency are included in our contracts. They are good for a year, typically, and cannot be changed without written agreement by the facility and the agency. So I cannot just randomly change my fees whenever I feel like it. The facility is free to go to another staffing agency at any time, and they are not forced to work with only one agency for their contract. They actually put in their contracts to let us know that they're going to work with 3 or 4 or 10 different agencies. Staffing agencies are hiring away staff from facilities due to us paying higher wages. Actually, the contract that I sign with my agencies, with my facilities, prevents me from hiring away their staff members. If I do that, I have to pay a fee. My staff, I work with my agency out on the floor with my staff. I have had people from my facilities ask me if they can come work for me, and I tell them no. I cannot hire them unless they have been gone from that facility for a year, per my contract and per my agreement with my facilities. If a nurse or tech from a staffing agency fails to report to duty with or leaves early, there's a CMS violation and the facility is short. I will tell you, I work for 4 different facilities with my agency. 9 times out of 10, it is not my staff that is calling in. It is the facility staff that's calling in and my team that's trying to fill in those holes. We work very close with my facilities to partner with them to make sure that we fill the holes that they need. Staffing agencies are sending staff who are not credentialed to take care of their residents. We have to go through the same credentialing, same CMS guidelines that our facilities go through. So everything that they're credentialing their people on, I'm doing the same thing. I also include that in a file to every one of my facilities before my staff goes into that door. By the way, on the platform one, I did talk to a couple of Skip, his people, and they are required to buy that insurance that he was talking about, the medical malpractice. They are required. They're not. It's automatically taken out of their funds here in Missouri. That's just from a couple of his staff. It is also stated, so here's my frustration. One of the things that was in the bill is we are not allowed to charge a fee if they try to hire away our staff. I have a minimal fee involved in that. If they want to hire one of my staff, they have to pay me a $5,000 fee, or my staff has to work full-time hours for them for 13 weeks, and then they can hire my staff without paying a dime. I have to credential my staff. I have to pay insurance. I send my staff to ACLS, BLS, all kinds of certifications and education to make sure that they are ready and they are the best staff for the facilities that I work for. And I will tell you, I will have 10 applicants for my agency. We will only hire typically 1 to 2 of those 10 applicants. We are very picky on who we hire. And I will tell you, there is many, many staffing agencies in the state of Missouri that live here. We're from these communities that we want to support our facilities. I think a lot of the biggest complaints you hear are from your larger investor agencies, not your locally owned people in our own communities. Thank you.
All right, thank you. In the interest of time, we'll move on without questions. We do have to be out of here by 6:15. Any other witnesses in opposition to the bill? There's no more in opposition? Next witness in favor of the bill. And again, we have to be out by 6:15, so we'll ask that you expedite your testimony. Thank you.
Hi, good evening. My name is Dove Winter. I'm the COO of MGM Healthcare. MGM has 24 skilled nursing facilities in the Midwest, and in Missouri alone, we represent 11 skilled nursing facilities. MGM's home office is in St. Louis. Our owners live here as well, and I myself grew up and lived in Missouri for most of my life. We are dedicated to our Missouri residents and employees and are always looking to invest more in this great state. Our Missouri facilities care for approximately 1,100 patients and residents on any given day.
Good evening. My name is Jody O'Mara, Chief Nursing Officer for MGM Healthcare. Like many others who have testified in favor of this bill, COVID and the staffing crisis has forced us to rely heavily on staffing agencies the past couple of years. And like everyone else, the residents are the ones who ultimately suffer. Agency staff do not know our residents. They do not follow policy and procedures. They do not provide sufficient documentation. In the end, this causes terrible surveys, negative outcomes. When these adverse outcomes occur, the agency staff members, long gone, on to the next facility, sometimes the very next day. Agencies disclaim any responsibility to the resident, their families, to our facilities, and to the state and federal government. When we are charged a fine or lawsuit as a direct result of an agency staff member, there's essentially nothing we can do to recoup the loss. In short, agencies are sucking out valuable facility funds and in return providing incredibly low level of care. They walk away with zero responsibility. We must ask ourselves, why are state and federal agencies holding our facilities responsible for these actions? Rather than to reiterate the general testimony of my peers, I'd like to answer a few questions that I heard last week and give a few examples of our own. There was a question, if you include the cost of payroll taxes and benefits to regular employees, is the gap between the agencies being paid still too large? The answer is resounding yes. Our rates are $14.75 for aides and $33.75 for RNs. Agency rates are $30 an hour and $58 an hour for RNs. Crisis pay ranges $45 an hour for CNAs and up to $83 an hour for RNs. This represents percentage increases from 71 to 205%. These numbers are staggering. Even if we take into account additional cost for regular employment benefits taxes, there's no comparison. Those additional amounts cost our facility on an average 11% on top of these base rates, which is demonstrated. It's nowhere near the additional cost for agency staff. Putting this into actual dollars, in 2021, our total agency spend in Missouri was just over $3.6 million, which is more than $1.5 million our spend would have been if we used regular employees. And of course, a large chunk of the increase is not even going to the nurses and the aides. It goes directly to the company who does not share in the responsibility of the services being provided. Another question, can we contractually deal with the fact that the agencies steal our staff and then charge us for rehiring them? The answer is resounding no. Every agency contract we sign has a clause that says that we must pay them direct hire fee if we hire one of their staff members. They charge us of this fee, even if we don't solicit the employee and the employee decides to leave on their own. Making matters even worse, they charge us this fee even when the same person worked for us prior to working for agency. Our legal department seeks to strike those provisions from the agency contracts, at the very least, to make it mutual so that if they hire one of our employees, they would need to pay us a direct hire fee. Not one agency has ever allowed that change. They say to us, take it or leave it. And we all know that we have no choice but to allow it. Just a few months ago, an agency charged us $20,000 for one nurse who no longer wanted to work for that agency. Agency staff members have no loyalty to our facility or to our residents. Agencies have created an environment which the only thing that matters is money and the highest possible rate. Employees routinely call off minutes before shifts. In most cases, they leave in mid-shift to go to another facility willing to pay a higher rate. This happens with many agencies, but notably, it routinely happens with ShiftKey. ShiftKey staff members who we know are opposing this important legislation. I would like to end with, I'm sure you've heard the White House recently announced its intention to create mandatory staffing levels. We plead that Missouri legislators will pass this bill. Hold staffing agencies accountable for price gouging, their lack of responsibility. If the proposed rule goes into effect, these agency concerns will only continue to worsen. Please, let's get this done.
Thank you. Thank you for your testimony. How many more do we have in support of the bill? We have 4 people. We've got a minute for each of you, minute or two for each of you. So,
thank you.
Thank you.
Let me establish a precedent for coming in under a minute. My name is Bill Bates. I'm CEO of Leading Age Missouri, which is a healthcare association for senior living and healthcare providers, 135 strong throughout the state of Missouri and mostly nonprofit. I will not repeat anything you've heard. My testimony was to bring you what I was hearing from my members, all of which you've heard in other testimony. However, I do want to associate Leading Age Missouri with the testimony and the study offered by the Missouri Healthcare Association and Nikki Strong last week. Our members contributed to that. I have seen members tonight citing that and referring to that. We helped support that. We believe in the conclusions reached there. Also, I brought and will bring up to Mrs. Anderson afterwards, when we were testifying here last week and during your hearing, Time Magazine was publishing an incredibly illuminating article on the very subject of what you're considering. I commend it to you. I will provide copies to her to be distributed later. And finally, one member did not contribute to the study that was provided before, and they pressed me very hard to share with you this information. In 2019, this member, which is not CMS certified, does not accept Medicaid. It's either private pay or when people run out of money, they just take care of them because that's their mission. And this provider had absolutely no agency use in 2019. In 2020, because of what COVID was doing, they had to use agency for 789 shifts. That tripled in 2021, again because of COVID, and the provider is on pace to be even higher in 2022. And what they shared with me was that from the beginning of their first time ever use of agency to now, the price has doubled. And it is unsustainable for this member, which has communities in Ozark, Chillicothe, Ironton, Ashland, and Independence throughout the state of Missouri. So we've got a real issue. We've got a problem. You're working to solve it. This is a very good bill that moves the needle, and we encourage you to move the bill forward. Thank you.
All right, thank you, sir. Next witness.
Mr. Chairman, I appreciate your time. My name is Ben Shulin. I'm the CEO and minority owner for JMS Senior Living. We have 9 facilities across the state. In lieu of the time, I have a really nice document here that I'm going to leave with you guys. I'm going to leave you also with one other thing is my office is here in Jeff City. If you have questions, I happily will drive to the Capitol any day and come and answer those questions for you. One final thought I do want to leave you with is, when we talk about providers in these agencies and who they are and what they are, remember, ducks walk, quack, and talk. So it's all the same, guys. Happy to answer your questions. Anytime you ever need me, I could be here in 10 minutes. Thank you.
All right, thank you, sir. Next witness in favor of the bill.
Thank you. I'm Mindy Martin. I am a nursing home administrator of 20 years, and I just wanted to take a moment to tell you that if we were paying more and getting more, we wouldn't be here. And our family members, our residents, and our staff that are W-2s would like to see change. So please push this bill through. There's a lot of work to be done. Thank you.
Thank you. Thanks for being here today. Last witness.
Good evening. My name is Luke Bucher. I'm the administrator at NHC Osage Beach Rehab and Healthcare Center. And I have some personal experience about the do not return issue that was brought up earlier. We have DNR'd hundreds of agency staff since July of 2020. That's when we first started getting agency. And every single DNR has been from ShiftKey. There hasn't been another staffing agency that we have DNR'd at my facility, but besides ShiftKey. And also, I just wanted to mention that we have had to halt admissions because of the staffing crisis that we're facing right now, which we're not doing a service to our state of Missouri because the more people that we can take care of, the better, because care is all of our business. Thank you.
All right, thank you, sir. That will conclude the hearing on House Bill 2605. Thank you all for being here. We're going to now move into executive session. Please call the roll for attendance.
Chairman Patterson.
Here.
Vice Chairman Davidson. Thank you. Representatives Ani. Cups. Fitzwater. Bogle. Gregory. Hafner. Hicks. McCrary. Ritchie. Stalls.
Here.
Smith. Taylor.
We have 13 present. We do have a quorum. I now move that we vote House Bill 2607 do pass. Discussion. This is Representative Roan's bill. Seeing none, I move that we vote do pass on House Bill 2607. Please call the roll.
Chairman Patterson.
Aye.
Vice Chairman Davidson. Aye. Representatives Ani. Aye. Cups. Yes. Fitzwater. Hess. Bogle. Aye. Gregory. Aye. Hafner. Aye. Hicks. Aye. McCrary. Yes. Ritchie. Aye. Stalls.
Aye.
Smith. Aye. Taylor. Fitzwater. No? Thank you.
By your vote of 12-1, you have voted do pass on House Bill 2607. Members, thank you very much for your work on this bill. That concludes the hearing. Thank you.